Welcome back to the deep dive. Today, we are undertaking, I think, a really critical mission, mastering the complex intersection of gynecology and urology.
That's right.
If you, or perhaps a patient you're caring for, have ever dealt with a gynecological issue or an obstetric one, chances are, well, urinary symptoms are probably part of the picture too.
Oh, absolutely. It's incredibly common.
And this connection, it isn't just common, it's profound. It goes right back to our earliest development. And, the consequences of not getting this right, of mismanaging this overlap, they can be truly life-altering.
That's absolutely right. And today, we're aiming to move beyond just sort of superficial knowledge. Our goal here is to really achieve an elite professional level of mastery.
Okay.
So we're going to methodically break down the pathology, the specific symptoms, and the management strategies, all based on our clinical source material. We'll analyze the dense anatomy, the physiology, moving systematically from those everyday complaints like frequency or pain, right up through the really serious, life-threatening complications, things like ureteric obstruction.
And we are dealing with information that demands really meticulous analysis and synthesis. It's dense stuff. Okay, let's unpack this then. Starting with the fundamental reason, really, why a gynecologist has to basically be a detective for the urinary system, that shared developmental history.
Exactly. The initial link is anatomical. It's embryological. You see, the urinary and genital organs, they develop in such close association in utero.
Right next to each other.
Precisely. So a failure or a malformation in one system really strongly suggests there might be a coexisting condition in the other.
Okay.
So if a gynecologist finds a significant structural issue, say in the genital tract, they have an absolute diagnostic mandate. They have to search for potential urinary tract anomalies.
And this isn't just, an academic point. Getting this wrong has really high-stakes consequences, doesn't it? Our source mentioned a terrifying scenario, mistaking a single kidney located down in the pelvis for a pelvic tumor. Why is that specific mistake so fatal?
Well, think about it. The consequence of mistakenly removing that kidney, if it happens to be the patient's only functioning kidney,
Oh, no.
is immediate, irreversible renal failure. It's catastrophic. And this extreme example, it really underscores the need for extensive diagnostic caution, especially when you find a pelvic mass and you're not sure of its origin.
So the gynecologist's role is fundamentally tied to spotting those urinary problems that are caused by the gynecological issues.
Yes, exactly. So they can institute the right, the rational, the curative therapy.
Mm-hmm.
And that always starts with confirming the integrity of the urinary system first.
So this goes way beyond just taking a simple history. What does the full diagnostic mandate actually involve, according to the sources, to really achieve this elite professional level of investigation and catch all these potential overlaps?
It means doing a full urological workup. If you suspect any problem, not just a quick physical exam, it involves getting a really detailed history, performing a meticulous physical examination, and then using a whole suite of advanced tools. We're talking full laboratory tests, cystoscopy that's looking inside the bladder.
Right, with the scope.
Exactly. Then radiological evaluation, like an intravenous pyelogram or IVP. That's the one using contrast dye to visualize the upper urinary tract, the kidneys and ureters, see how they're structured and functioning.
Mm-hmm.
Then there's cystometry, which measures bladder capacity and pressure dynamics. And finally, of course, ultrasound scanning.
I want to pause on the IVP for just a second. Why is that specific test, focusing on the kidneys and ureters, so critical, even if the patient's symptoms seem purely lower tract, bladder or urethra related?
That's a great question. It's because those lower tract symptoms might actually be mirroring a problem higher up. If we see, say, a dilated ureter or a hydronephrotic kidney, a swollen kidney on the IVP, that immediately tells us there's an obstruction somewhere lower down. And that obstruction is likely caused by a gynecological mass or maybe advanced cancer. The IVP gives us the bigger picture, the functional and anatomical integrity of the entire system. It stops us from overlooking those silent, dangerous compressions we'll definitely talk more about later.
That level of investigative rigor brings us to a really specific and, I think, profoundly important exclusion: neurological causes. This seems key because sometimes the underlying disease might have, as the source says, no gynecological bearing at all, but it presents like a urinary issue.
Precisely. When we're assessing retention, the inability to void, it's absolutely crucial to try and exclude neurological causes right away.
Okay.
And the source specifically flags this for patients who cannot void, but critically, experience no painful sensation. That lack of pain is the big diagnostic clue.
Why is the lack of pain so revealing here?
Well, it's fascinating, actually. Most patients who have acute bladder sensation problems, maybe from an infection or acute blockage, they do feel pain, often severe pain, because the bladder is overdistended or inflamed.
Makes sense.
So finding retention without pain should immediately raise a red flag for possible denervation. It suggests something like a spinal cord lesion, maybe disseminated sclerosis, even something like Taves dorsalis that's a late complication of syphilis,
Wow.
all of which need immediate, separate neurological investigation. So that contrasts pain, usually meaning local inflammation or blockage, but lack of pain pointing toward a neurological disconnect. That's a really powerful diagnostic distinction, one we absolutely need to internalize for that elite understanding.
Okay, so we've laid the foundation, established the diagnostic rigor needed. Now, let's dive into those common urinary symptoms that are seen day in, day out. Retention, difficulty, pain, frequency, and incontinence. Let's begin with the most acute and often the most painful one, acute retention of urine. That sudden inability to pass urine.
Right. Acute retention is typically defined by significant discomfort and often intense pain. Clinically, when you pass a catheter, you characteristically get a large volume of urine back, often well over 500 milliliters. The key is to categorize the causes, because that points directly to how you need to manage it. Hashtag A. Acute retention of urine, sudden inability to void.
Let's break down those causes then, starting with the one most directly relevant to gynecological practice, postoperative retention.
Yes, this is extremely common after pretty much any vaginal or perineal surgery. The mechanism is sort of twofold. First, you get local postoperative edema, swelling, which causes a direct physical obstruction at the bladder neck.
Okay.
And second, the pain from the surgical site leads to a reflex spasm of the external urethral sphincter. It just clamps down, preventing relaxation.
But the surgical technique itself can fundamentally change that mechanism, can't it? Especially in those really radical cases like a wartime hysterectomy.
Correct. The really extensive pelvic dissection you need for a radical hysterectomy can actually cause denervation of the bladder. It damages the sensory and motor nerves. And the result is an insensitive bladder. It can't contract effectively, and crucially, it can't signal its fullness to the patient. So this leads not just to retention, but specifically retention with overflow. The bladder just keeps filling passively and eventually leaks.
Right.
And similarly, we often see a temporary loss of sensation or denervation in the first, say, 12 to 24 hours after surgery, just from the effects of spinal and epidural anesthesia.
Okay. Moving beyond surgery, peripheral retention. So retention after childbirth, that's another frequent one.
Yes. Here, the mechanism is mostly about sensation and reflexes. There's often bruising of the vagina, and the intense pain from perineal wounds, like an episiotomy, means the patient often just can't appreciate that her bladder is filling up, or she can't consciously relax the sphincter to void in that immediate postpartum period.
The sources also detail structural causes, actual obstructive conditions. While intrinsic urethral strictures are apparently rare in women, what are the main culprits when we're looking for a fixed blockage?
We need to look for intrinsic pathology. Things like cicatricial stenosis, that's scarring, which can happen after lower urethral surgery, or perhaps repairing a urinary fistula.
Okay.
We also need to consider infiltration caused by advanced cancers. Carcinoma of the cervix, vagina, bladder, or urethra can physically grow into and block the outflow tract.
And then there's the iatrogenic risk, the unintentional harm from surgery. The text specifically warns about being a bit too enthusiastic with surgery for stress incontinence.
Yes, it does. The source cautions that sling operations for stress incontinence, if they're performed with undue enthusiasm, might actually achieve complete occlusion, completely blocking the bladder neck.
Resulting in acute retention.
Exactly, full retention. And the only cure in those cases is typically more surgery to actually cut or release the sling. It's a sobering reminder, isn't it, that a treatment designed to fix one functional issue can inadvertently create a much worse mechanical one.
Definitely. Now, for the space-occupying lesions, that list of pelvic masses that can physically block the outlet or just distort the anatomy.
Yes, this list is crucial for the differential diagnosis. Let's run through them. First, hematocolpos. This happens in adolescents with an imperforate hymen. Menstrual blood gets trapped, builds up in the vagina, and pushes the bladder upwards, blocking the exit.
Okay.
Second, a retroverted gravid uterus. This is when the pregnant uterus fails to tip forward as it grows. Usually around the 12th to 14th week, it gets stuck backwards.
We'll come back to that one.
Third, a hematocele, which is a collection of blood in the pelvis, often after a ruptured ectopic pregnancy.
Right.
Fourth, uterine myomas or fibroids. specifically those growing large on the cervix or the posterior wall of the uterus, which can get impacted down in the pouch of Douglas. And fifth, impacted ovarian neoplasms, tumors, benign or malignant, that drop down and get wedged in the lower pelvis.
So, regardless of the cause, the immediate treatment for acute retention is pretty standard, isn't it?
Yes, the management starts with prompt and continuous catheterization. You need to keep the bladder empty until the residual urine volume, the amount left after trying to void, is reliably less than 100 milliform.
Okay, let the bladder rest.
Exactly. Decompress it, allow it to regain its tone, and this absolutely must be combined with urinary antiseptics to guard against the almost inevitable infection that comes with catheterization.
Right, that 80% risk.
Precisely. And also analgesics for pain relief.
Let's really focus now on the retroverted gravid uterus, because the mechanism there is diagnostically quite unique. Why does the retention tend to happen specifically around the 12th to 14th week, and why isn't it a true physical blockage?
Good points. Around 12 weeks, the uterus is growing fast and normally starts to lift up out of the pelvis. If it fails to do that, if it stays tipped backwards, retroverted, it sinks lower, effectively jamming itself in the pelvic hollow.
Okay.
This mass then stretches the anterior vaginal wall and, crucially, the attached urethra and the trigone of the bladder. This anatomical distortion causes a disturbance of the reflex mechanism of voiding, rather than a simple physical blockage like you'd get from a solid tumor.
And the proof is?
The proof is that a soft catheter usually passes quite easily, even though the woman can't urinate. If it were a solid blockage, you'd struggle to get the catheter in.
So, since it's more of a reflex issue, how does the specific treatment differ from managing, say, a tumor obstruction?
The treatment aims to decompress the bladder slowly and then encourage the uterus to reposition itself. Slow emptying, usually with an indwelling catheter left in for 12 to 14 hours, helps prevent bladder shock and maximizes the chance of the uterus spontaneously tipping forward.
Right.
The patient is also encouraged to adopt postural changes, specifically lying prone on her face. Gravity can help encourage the gravid uterus to assume the correct anteverted position.
And the source gives a very explicit warning about trying to push it back manually.
Yes, very clearly stated. Digital repositioning of the retroverted gravid uterus is strongly not recommended. It's considered neither safe nor successful and carries significant risks of trauma. So, catheter and posture, not manipulation. Hashtag chronic retention with overflow.
Before we leave retention, just a quick word on the chronic version. This often keeps up on older women and can present in a slightly paradoxical way.
That's right. Chronic retention with overflow is a common issue related to senile changes. It's typically caused by age-related loss of elasticity and narrowing at the bladder neck, maybe due to fibrosis or hardening of the urethral outlet tissues.
So the bladder just gets chronically overstretched.
Exactly. It becomes chronically overdistended. And the paradox is that the patient often presents not with an inability to void, but with increased frequency or even incontinence, constantly leaking small amounts of urine.
Ah, because it's overflowing.
Precisely. The bladder is full past its capacity and is just passively overflowing, rather than the acute situation where they simply cannot initiate voiding at all. Hashtag C. Difficult micturition.
Okay, let's move on to difficulty in micturition, that feeling of straining to empty the bladder, which often precedes full retention.
Yes, difficult micturition can occur with chronic conditions like bladder growths or urinary stones, but the most common and really classic gynecological cause is a severe degree of prolapse of the anterior vaginal wall specifically, a large cystocele, or even complete procedentia.
This mechanism is one of the most sort of visually illustrative in this whole field, isn't it? How does severe prolapse actually stop someone from emptying their bladder easily?
It creates what you can think of as a hydrostatic trap. When the patient strains to urinate, the prolapsed anterior vaginal wall bulges downwards even further, creating a large sacculation of the bladder, the cystocele.
Okay.
Now, this sac often lies below the level of the internal urinary meatus, the bladder outlet. So the straining effort, instead of pushing urine out through the urethra, actually forces more urine down into this cystocele sacculation, pushing it deeper into the vagina, away from the outlet.
So the harder she strains, the worse it gets in a way.
Exactly. The harder she strains, the fuller the dependent part of the cystocele becomes.
Which leads to that famous splinting maneuver, which is really a diagnostic sign in itself.
Absolutely. The patient learns, usually through sheer necessity, that the only way she can start voiding or properly empty her bladder is by manually pushing back the prolapsed anterior vaginal wall with her fingers. She has to splint the area, lifting the cystocele so the bladder base is above the level of the meatus.
And the treatment is obviously fixing the anatomy.
Yes, the only rational and curative treatment here is surgical repair of the anatomical defect. An anterior colporrhaphy, usually combined with a pelvic floor repair and often a vaginal hysterectomy if that's indicated as well. #tag painful micturition. Bacteria.
Moving on to pain or dysuria, we touched on this earlier. The timing of the pain is the crucial diagnostic clue, differentiating between bladder versus urethral origin.
Yes, this timing distinction is absolutely paramount. Pain of vesical origin, so from the bladder itself, is typically felt either during the act of voiding or, more characteristically, immediately following micturition.
Why afterwards?
Because once the bladder is emptied, it spasms, and the inflamed internal surfaces come into apposition, they touch each other. This spasm is felt quite severely, usually in the mid-hypogastrium, right above the pubic bone. And it gives the patient an immediate painful urge to pass urine again, even though the bladder is technically empty. That's the classic presentation of cystitis.
Okay. And conversely, if the pain originates in the urethra,
then that pain is referred specifically to the urethra, and it's felt as the urine is actually passing over the inflamed mucous membrane. Patients often describe it as a scalding or burning sensation during the act of urination.
and the source gives gynaecological urethritis as a classic example.
Yes, but really any local inflammation or trauma to the urethra can cause that type of pain.
The source also lists quite a few specific causes related to the vulva and the urethral opening, especially in older women.
Yes, we have to carefully inspect the external structures. Look for things like tender urethral caruncles, prolapse of the urethral mucous membrane itself, and also vulval diseases like chlorosis. That's a rare condition causing atrophy and shrinkage of the vulval skin, or even carcinoma of the urethral meatus.
And we can't forget the trauma-induced cause, honeymoon cystitis.
Right? I've called that humorously, but it's clinically accurate. Trauma during intercourse causes local urethral inflammation, leading to pain and frequency.
And then there's a major cause linked directly to pelvic cancer treatment, radiation cystitis. This really speaks to the potential long-term cost of a cure.
Yes. Radiation cystitis is a severe, often chronic complication that can follow radium treatment, historically used for cervical carcinoma. The radiation damages the bladder lining. In severe cases, it causes a small capacity, highly irritable bladder, which is profoundly distressing for the patient.
And there's a visual sign on cystoscopy.
Yes. Often on cystoscopy, the post-radiation bladder shows characteristic telangiectasia. These are small, visible, dilated blood vessels, especially in the trigone area. It's a hallmark of radiation injury.
So given the potential for serious underlying issues like stones or cancer presenting as dysuria, what's the required diagnostic workup?
It absolutely has to be meticulous. It starts with a comprehensive urine analysis and culture to rule out infection straight away. But then you must proceed to cystourethropy, looking inside both the bladder and urethra to definitively exclude those serious, potentially life-threatening causes like a stone, tuberculosis, a papilloma, or carcinoma. You can't just assume it's simple infection. ###EA, increased frequency of micturition.
Okay, finally in the section, frequency. The source defines this quite precisely. Voiding urine more than 8 times during the day and more than once during the night. And it's probably the single most common urinary complaint overall.
It really is. And the first step is always to differentiate the polyuric causes, where the patient is genuinely producing large volumes of urine, like in diabetes mellitus or insipidus, or the polyuric phase of renal failure.
Great, systemic causes.
Exactly. Differentiate those from local gynecological causes that are either reducing the bladder's functional capacity or increasing irritation.
Okay, what are the common local causes?
Well, frequency is physiologically normal in early pregnancy due to the growing uterus pressing on the bladder, and again in late pregnancy due to pressure from the presenting part, the baby's head usually.
Makes sense.
Pathologically, it can be caused by direct pressure from pelvic tumors, things like large myomas or ovarian cysts, or it can be due to chronic irritation, for instance, chronic cystitis that results from incomplete bladder emptying, often seen with a significant cystocele.
And again, the more ominous signs related to advanced cancer.
Yes, direct infiltration of the bladder wall by carcinoma of the cervix or vagina is a very serious cause. It rapidly reduces the bladder's functional capacity and causes significant irritation, leading to severe frequency.
However, there's one really crucial differential diagnosis here, one that's easily confused with stress incontinence because both can involve frequent urges to go, and that's bladder neurosis. This is where the physical and the psychological really seem to intersect.
This is a key area, especially for the advanced learner aiming for mastery. In established bladder neurosis, The patient's entire life can become dominated by her bladder function. But a crucial diagnostic clue is that this anxiety and frequency are typically present only during the daytime.
Ah, okay.
The diagnosis really hinges on exclusion. The urine must be sterile, cystoscopy must be normal, and no other organic local cause can be found despite thorough investigation.
How does the nocturia score the number of times someone gets up at night to help differentiate this neurosis from an actual organic lesion?
That's a useful pointer. Frequency caused by an underlying organic problem like a genuinely small, irritable bladder due to chronic cystitis or cancer infiltration tends to occur fairly equally both day and night.
Right.
Therefore, the nocturia score gives a rough, immediate indication of the likely severity of an underlying organic lesion. If a patient tells you she's voiding maybe 15 times during the day but never ever wakes up at night to go, bladder neurosis moves much higher up the list of possibilities.
And since there's no organic problem to fix, the management for bladder neurosis is completely different, isn't it?
Absolutely. Treatment moves away from things like antibiotics or surgery. According to the source, it's based on simple applied psychotherapy, bladder discipline, which means retraining the bladder to hold urine for gradually increasing intervals, and sometimes sedatives, really just to help break that anxiety frequency cycle.
Okay, now we get to incontinence, the involuntary loss of urine. And here, clarity is absolutely paramount. We really need to distinguish between constant leakage, leakage that only happens on exertion, and leakage that's preceded by an overwhelming sudden urge. Let's start with true incontinence. Hashtag A. True incontinence, constant wetness.
Right. True or complete. Incontinence means involuntary and continuous leakage. The patient is basically constantly wet. This only occurs when there's a pretty severe anatomical disruption.
What are the main causes that lead to this kind of constant flow?
The most common causes are either a vesicovaginal fistula or a ureterovaginal fistula. These are unnatural connections, holes really, between the urinary tract and the vagina, usually resulting from surgical or obstetric trauma.
Okay.
Much rarer causes include congenital malformations, like ectopia vescae, where the bladder is essentially outside the abdominal wall, or an ectopic ureter, where a ureter opens directly into the vagina instead of the bladder. Certain spinal cord diseases can also cause it.
And there's a diagnostic clue based on how much urine is left in the bladder, isn't there? A quick way to differentiate between the two main types of fistula.
Yes, that's a key initial differentiator. In a vesicovaginal fistula, because the bladder is draining completely out through the hole into the vagina, the bladder is always essentially empty. There's basically no residual urine.
Okay.
But in a ureterovaginal fistula, one ureter is bypassing the bladder and draining into the vagina, but the bladder still receives urine normally from the other, unaffected kidney and ureter. So in this case, the bladder typically contains only about half the normal expected volume of urine. Measuring that residual volume is a crucial first step. Hashtag B, false or partial incontinence.
Okay, so that's true, constant leakage. False or partial incontinence is much more common. It includes things like nocturnal enuresis, bedwetting in young girls, but it's really dominated by the clinical challenge of distinguishing between stress and urge incontinence. Let's start with stress urinary incontinence, SUI.
Right. SUI is the very common type, often associated with anterior vaginal wall prolapse and general pelvic floor weakness. The absolute key feature is the involuntary loss of small, minimal, measurable quantities of urine, typically just a few milliliters.
And only when?
And it occurs only when intra-abdominal pressure is suddenly and rapidly raised. Things like sneezing, coughing, jumping, laughing. Critically, the patient has no previous desire to pass urine right before the leak happens. It's an immediate mechanical failure of the sphincter mechanism under pressure.
Okay, that's clear. Now contrast that sharply with urge incontinence, also known as detrusor instability.
Urge incontinence is often clinically more severe for the patient, and functionally, it's actually thought to be more common than true SUI. This is caused by detrusor instability. That means that the bladder muscle, the detrusor, contracts involuntarily, often quite forcefully, and it overcomes the normal resistance of the urethral sphincter.
So it's the bladder misbehaving.
Essentially, yes. The patient experiences an extreme, sudden, overwhelming desire to void urgency. They feel they absolutely must reach the toilet at a moment's notice.
And if they don't make it?
If they fail to reach the toilet in time, they risk emptying considerable amounts of urine, sometimes even the complete contents of the bladder. It can be, as the source says, a catastrophic event for them socially and emotionally.
So just to summarize that critical difference, SUI is a mechanical failure, minimal leakage, happens only on physical stress, and there's no warning urge beforehand.
Correct.
whereas urge incontinence is more of a neurological or functional failure of the bladder muscle itself, leading to a severe, overwhelming warning urge and potentially large volume leakage if they don't get there fast enough.
Precisely. The pre-event sensation is the absolute opposite of SUI. And while cystoscopy and urge incontinence is generally normal, it might sometimes show a decreased bladder capacity because the bladder is chronically irritable. The underlying pathology is often functional, but it can be triggered or worsened by organic issues like a true cystitis or underlying urinary infection.
And getting that distinction right, which relies almost entirely on taking a careful history about the quantity of leakage and the presence or absence of urgency,
Is absolutely vital
Yeah.
because the management protocols for SUI and urge incontinence are entirely different. You treat them in completely different ways.
Okay, let's shift focus to infections. These are a constant threat in the female urinary tract, mainly because the urethra is relatively short and wide. Let's look first at cystitis, the lower UTI, and really focus on the pathogenesis, how it actually happens. #tag a cystitis, lower UTI.
Right. It's important to remember the female urethra isn't sterile. It normally harbors various microorganisms, coliform bacilli like E. coli, streptococcus, staphylococcus, even Dodderlein's bacilli from the vagina.
Okay.
Now, these are usually part of the normal flora, and they don't cause urethritis or spread up into the bladder unless the urethral tissues get damaged or the organisms are actively transported upwards, typically against the normal flow of urine.
And the primary mode of transport upwards in the gynecological and obstetric setting is the catheter.
Yes. Catheterization is singled out as the single most common cause of lower UTI in this context. The source notes that because catheter use is almost integral to many procedures, like managing difficult deliveries or complex gynecological operations, the incidence of resulting cystitis must be accepted as being somewhere in the region of 80%.
80%, that's staggering, especially for frequent or long-term indwelling catheter use.
It is. It's an incredibly high figure.
That statistic really feels like a call to action. What's the logical prophylactic approach then to try and mitigate this huge risk?
The clinical texts advise a two-pronged strategy. First, fundamentally question the need. Abolish the use of catheters as just a routine preoperative measure in minor pelvic surgery if it's not strictly necessary.
Okay.
Second, when a catheter is strictly indicated, the advice is to administer a urinary antiseptic immediately as a prudent prophylactic precaution. Don't wait for symptoms to develop. Try to prevent the infection from taking hold in the first place.
Beyond direct spread via catheter, what are the other routes by which infection can reach the bladder?
Well, organisms can descend from the kidney, for instance, in cases of renal tuberculosis or chronic pyelonephritis. Infection can spread from adjacent inflamed structures, like an inflamed cervix or parametritis following pelvic surgery or infection. Less commonly, we might see blood-borne spread or lymphatic spread, perhaps from the genitalia or even the bowel.
And the most frequent offending organism?
By far, it's E. coli.
What happens sometimes during or after antibiotic treatment that can change the type of bacteria we find?
Ah, yes. Due to the intense antibiotic pressure, particularly in complicated cases or hospital-acquired infections, organisms that have inherent resistance can emerge. Things like Pseudomonas pyocyania or certain strains of Klebsiella sometimes become the dominant infecting organism, effectively replacing the initial E. coli population that was susceptible.
So you have to consider that if the first antibiotic doesn't work.
Exactly. It's a key reason why culture and sensitivity testing is so important, especially in resistant or recurrent infections.
Let's quickly review the typical clinical picture of acute cystitis. What does the patient experience?
Typically, they have painful and frequent micturition. The pain is often described as strangury. That's a painful, unproductive, spasmodic urge to urinate. Pus is usually passed in the urine. There's often localized bladder pain and tenderness just above the pubic bone.
And that signature timing of the pain?
Yes, the signature is pain felt most intensely right at the end of the act of urination, as those inflamed bladder surfaces come into contact. Frequency can be incredibly severe, sometimes needing to pass urine every 15 or 20 minutes, which obviously leads to profound patient exhaustion.
And a high temperature is a worrying sign.
Yes, if a high temperature persists, it's a strong indicator that the infection is likely ascending up towards the kidneys, becoming pyelonephritis.
This brings us back to that diagnostic challenge. Distinguishing acute cystitis from acute urethritis, especially since both might present with pus in the urine.
Yes, and we rely heavily on two things here: the timing of the pain and the classic 3-glass test.
Okay, remind us of those.
Pain timing. In urethritis, the pain is typically felt during the act of urination, as urine flows over the inflamed urethra. There's usually no significant abdominal pain, and the frequency isn't usually as extreme as in cystitis. In cystitis, remember, the pain peaks at the end of urination and is often accompanied by that suprapubic abdominal pain.
Got it. And the three-glass test.
The patient voids sequentially into 3 separate containers. In isolated urethritis, the first specimen, which washes out the urethra, contains pus. The second and third specimens, representing bladder urine, should be clear.
Okay.
In cystitis, however, because the bladder itself is infected, all 3 specimens will be contaminated with pus and bacteria, often with even more pus appearing in the later specimens as the bladder walls contract more fully.
And there's a key warning about using instruments during the acute phase, particularly with urethritis.
Absolutely. In acute urethritis, any instrumentation trying to pass a catheter or perform cystoscopy is strictly contraindicated. There's a high risk of physically carrying the infection from the urethra up into the bladder or causing further damage to the acutely inflamed urethral lining, which just makes everything worse for the patient.
Makes sense. For treatment, besides the obvious like bed rest and pushing fluids, what pharmacological measures are emphasized in the source?
Right. The acute phase needs bed rest, local comfort measures like a hot water bottle over the bladder area, and avoiding alcohol, which is a known bladder irritant. Spasmolytics like codeine or belladonna preparations can help manage the pain and those frantic, distressing urges.
And crucially, citrates.
Yes, crucially, large doses of citrates are recommended, typically 3 grams of potassium citrate taken 3 or 4 times a day.
Why the big emphasis on citrates? What do they actually do?
Citrates are powerful alkalinizing agents. By increasing the pH of the urine, making it less acidic, they achieve 2 things. First, they make the urinary environment less hospitable for the growth of many common pathogens, especially E. coli. Second, they significantly decrease the painful burning sensation that occurs when acidic urine passes over already inflamed tissues.
So it helps symptoms and potentially hinders the bacteria.
Exactly. Then, of course, antibiotic selection should ideally be guided by culture and sensitivity results. Nitrofurantoin is often mentioned as being highly effective against E. coli, while drugs like ciprofloxacin or norfloxacin are standard first-line choices in many guidelines now. ## B. pyelonephritis, upper UTI.
Okay, let's move up the track now to pyelonephritis. This signifies a much more serious ascending infection involving the kidneys and the upper urinary tract, often following an uncontrolled lower UTI.
Yes, pyelonephritis is a common and serious complication. We see it frequently during pregnancy again. E. coli is the usual culprit, or as a direct spread from postoperative or puerperal cystitis that wasn't adequately treated. But its most ominous association in the gynecological context is undoubtedly with advanced pelvic malignancy.
We really have to address that critical and, frankly, sobering statistic related to cancer again here. This fact truly epitomizes the danger lurking at this gynecology-urology intersection.
It does, and it's a fact that every clinician dealing with pelvic disease needs to have front of mind for that elite professional understanding. Offending pyelonephritis is a common consequence of advanced carcinoma of the cervix and vagina. This often happens through direct tumor involvement or compression of the ureters as they pass through the pelvis. And the source states quite starkly that at least 60% to 70% of patients with advanced carcinoma of the cervix ultimately die of uremia induced by bilateral ureteric obstruction.
Not from the cancer spreading elsewhere, but from kidney failure caused by the local pelvic disease blocking the ureters.
Precisely. The cancer essentially strangles the plumbing, leading to kidney failure, which is, in theory, preventable or manageable if detected early enough.
So what are the signs and symptoms of this severe upper tract infection? How does pyelonephritis present?
The symptoms are usually much more systemic and severe than cystitis. Patients typically experience intense pain and deep tenderness felt in the loins in the kidney area. This is coupled with a high temperature, often with frequent chills or rigors. Headache, vomiting, and signs of systemic illness like a furred tongue are common. There might still be frequency if there's associated cystitis.
And in acute cases?
In acute pyelonephritis, the kidney region on the affected side can be exquisitely tender to palpation. The patient appears severely ill, showing signs of toxemia, systemic poisoning from the infection. Blood tests often show raised blood urea levels, indicating impaired kidney function, and urine analysis will show casts, pus cells, and bacteria.
What about chronic cases?
Chronic cases might present with less severe pain, but you can often still detect tenderness and maybe some rigidity along the course of the affected ureter on an abdominal examination. The urine remains turbid, containing pus and bacteria.
Treatment for acute pyelonephritis clearly requires a more aggressive systemic approach.
Absolutely. The patient needs strict bed rest, ideally positioned lying on the unaffected side to minimize pressure on the tender infected kidney. Copious fluid intake is essential. And systemic antibiotics are required, often started intravenously in severe cases to achieve high blood levels quickly, followed by a sustained course of oral antibiotics for usually 10 to 14 days.
And referral might be necessary.
Yes, any case that is recurrent or doesn't respond promptly to initial treatment absolutely must be referred to a urologist. There may be underlying anatomical issues, obstruction, or stones that need further investigation and management, particularly in chronic pyelonephritis.
Okay, let's narrow our focus right down now, specifically to localized pathology within the urethra itself. This is an area where local trauma, infection, and particularly hormonal shifts can play a massive, yet sometimes quite subtle role. Let's start with straightforward urethritis. Hashtag A urethritis.
Right. Urethritis is essentially an inflammatory disorder of the urethra. It's often related to sexually transmitted diseases, the gonococcus, chlamydia trachomatis, trichomonas vaginalis, candida, even viruses can cause it. Typically, it affects the lower part of the urethra and frequently occurs alongside vulvovaginitis.
We touched on this earlier, but let's elaborate on the particular susceptibility of menopausal women. That hormonal link seems really key here.
It absolutely is. The estrogen deficiency that occurs during and after menopause causes significant thinning and atrophy, a kind of wasting of the lining epithelia of both the vagina and the urethra.
Okay.
This makes the tissues much more fragile, less resilient, and poorly protected, so they become extremely vulnerable to minor trauma, like from intercourse, and also much more susceptible to secondary infection.
And it's not always infectious.
No. We also see non-infectious urethritis caused by chemical irritants. Things like perfumed deodorants used in the genital area, harsh douches, certain vaginal contraceptives, even prolonged tampon use in some individuals.
What really stands out diagnostically when comparing urethritis to cystitis?
As we established, the main thing is timing of the pain. In urethritis, the pain or burning is felt during micturition, not typically at the end. The main symptoms are frequency and dysuria. Clinically, when you examine the patient, you might see an inflamed urethral orifice, the opening, and sometimes gently milking the urethra downwards from inside the vagina might express a purulent discharge.
And treatment?
Treatment involves appropriate antimicrobials. If an infection is identified, things like ampicillin, nitrofurantoin, or cephalosporins might be used depending on the likely pathogen. Adequate fluid intake is important. But critically, for the menopausal patient, supplementary vaginal estrogen cream is often essential. It helps restore the health, thickness, and resilience of the local tissues, and of course, avoiding any potential chemical irritants. Hashtag B urethral syndrome.
Okay, now onto something called the urethral syndrome. This sounds like a distinct clinical entity, maybe a diagnostic challenge that requires real skill to identify correctly.
It is, and it presents a classic clinical profile. Typically, it's a postmenopausal woman who comes in complaining of dysuria, frequency, and sometimes even a bit of low-level stress urinary incontinence.
But the crucial finding is?
The key finding is that her urine is completely sterile on culture. This immediately rules out common bacterial cystitis or urethritis, leaving us looking for a functional or, more likely, a hormonal cause.
So once infection is definitively excluded, the focus shifts straight to that estrogen deficiency.
Precisely. The underlying cause is defined primarily as chronic estrogen deficiency. This leads not only to those atrophic mucosal changes we just discussed, but also potentially to some weakening of the internal urethral sphincter mechanism.
And the good news is it responds well to treatment.
Yes, the syndrome is generally highly receptive to treatment. Simple vaginal estrogen cream applied locally works very well. It improves blood flow, restores the epithelial thickness and resilience. Symptoms often start to improve significantly within about 3 months of starting treatment. It's a really critical example of how targeted local hormone replacement can effectively resolve quite distressing localized symptoms.
But the source mentions the syndrome can also appear in younger women, where estrogen deficiency obviously isn't the primary issue.
That's true. In younger women presenting with similar symptoms, dysuria, frequency, sterile urine, if you find pus cells in the urine despite the sterile culture, you have to maintain a high index of suspicion for infection with atypical or slow-growing organisms. Things like tubercle bacilli, TB, or chlamydia trachomatis need to be considered as they require specialized testing and very specific treatment regimens. Hashtag C structural and lesion-based conditions.
Okay, let's move from inflammation and hormonal effects to specific structural lesions within or around the urethra, starting with the urethral caruncle, which is apparently common in the postmenopausal period.
Yes, a caruncle is a small, benign, tumor-like mass, often polypoid. It's common in postmenopausal women, partly because the surrounding vulval tissues tend to atrophy, leaving the urethral meatus more exposed and potentially subject to chronic irritation.
What does it look like?
It typically appears as a swollen, bright red, highly congested area of granulation tissue, often protruding from the posterior aspect of the urethral meatus. The source describes it vividly as pouting like a cherry.
And the symptoms?
Symptoms can include bleeding after intercourse, pain during sex, dyspareunia, local tenderness, and dysuria.
Why is the diagnostic caution so high before just treating what looks like a small, benign caruncle?
It is absolutely imperative to exclude underlying malignancy, particularly genital tract malignancy, before you confidently diagnose and treat a caruncle. Carcinoma of the urethral meatus itself can sometimes mimic the appearance of a benign caruncle.
So you need to rule out worse things first.
Exactly. Necessary screening, like cervical cytology, maybe even endometrial histology depending on other symptoms, must be performed. Sometimes a direct biopsy of the lesion itself is required just to be certain. Once malignancy is excluded, the treatment is usually diathermy excision, essentially burning it off. And this should ideally be paired with long-term systemic or local estrogen therapy to address the underlying atrophy.
With a note about progestogens.
Yes, with intermittent progestogens added, if using systemic estrogen, to protect the uterus and potentially the breast from the risks of unopposed estrogen stimulation.
Okay. Briefly, what about urethral prolapse? What causes that?
Urethral prolapse involves the extrusion, the turning inside out of the entire circumference of the urethral mucous membrane through the meatus. It's relatively uncommon, seen mainly at the extremes of life in the very young and the very old. Contributing factors are thought to include chronic straining, like with constipation, and again, estrogen deficiency in older women. Treatment is typically surgical excision of the redundant prolapse mucosa, carefully suturing the remaining healthy edge back to the circumference of the meatus.
Then there's the urethral diverticulum. This sounds like it could cause quite confusing symptoms, needing careful differentiation.
Yes, a urethral diverticulum is an outpouching from the urethra. The symptoms it causes are notoriously nonspecific and variable. Patients might present with frequency, dysuria, dyspareunia, post-void dribbling, urgency, sometimes even frank incontinence. Often there's a tender swelling felt in the anterior vaginal wall in the region of the urethra.
And differentiating it from other swellings.
Exactly. It needs to be carefully differentiated from other potential swellings in that area, like a simple urethral, which is just sagging of the urethra, not a distinct pouch, a Gartner's duct cyst, a remnant from embryonic development, or an abscess in Skene's glands, which are located near the urethral opening.
How is it treated?
Treatment usually involves antibiotics first to clear any infection within the diverticulum, followed by surgical management, typically either complete excision of the sac or sometimes marsupialization, which means creating a permanent opening from the diverticulum into the vagina. But patients need to be counseled about potential complications, which include subsequent urethral stricture formation or developing a urethrovaginal fistula.
Finally, in this section, urethral stenosis, a narrowing of the urethra.
Yes, stenosis or narrowing commonly occurs at two main sites, the bladder neck itself or right at the external meatus. The causes are varied. It can be congenital, present from birth, or acquired due to infection, injury, including surgical trauma, neoplasms, or even secondary to a diverticulum.
And the symptoms?
Symptoms are typically those of outflow obstruction, a poor urinary stream, needing to strain to void, and often recurrent UTIs because the bladder doesn't empty completely. Urethroscopy, looking inside, might show the narrowing itself and often reveals secondary changes in the bladder wall, like trabeculation, due to the chronic straining.
Treatment depends on the cause.
Yes. First, control any active infection. Then, address the underlying cause if possible, remove cysts or tumors. Definitive treatment for the stenosis itself might involve intermittent urethral dilatation, stretching the narrowed area, a surgical procedure called urethrotomy, cutting the stricture, or sometimes more complex reconstructive urethroplasty.
Let's transition now to what are arguably the most serious structural complications we encounter at this interface, conditions resulting from major trauma, complex surgery, or advanced malignancy. Let's begin with urinary fistulae. #UN urinary fistulae.
Right. Urinary fistulae, these abnormal communications or tunnels between the urinary tract and the genital tract are overwhelmingly the result of either injury during gynecological operations or severe obstetric damage during childbirth.
And the source makes a very clear geographical distinction in terms of the most common cause.
Yes, it does. In developing countries, particularly places like India mentioned in some texts, the obstetric fistula unfortunately remains the dominant cause. This typically results from prolonged, unrecognized obstructed labor, often during difficult home deliveries. The sustained pressure from the baby's head against the pelvic bone cuts off blood supply, leading to pressure necrosis tissue death in the bladder wall or urethra, creating the hole.
Whereas in developed countries,
In contrast, in developed countries with more accessible obstetric care, fistulae usually occur following surgical trauma during planned interventions, or sometimes as a complication of radiation therapy for pelvic cancers.
what are the two most common types of fistula encountered?
By far the most common type is the vesicovaginal fistula, BVF. This is a connection between the bladder and usually the upper third of the anterior vaginal wall. The next most frequent type is the ureterovaginal fistula. This typically results from accidental injury to the ureter during a complex gynecological operation, like a difficult hysterectomy, especially where the ureter runs very close to the major uterine blood supply that needs to be clamped and cut. #B ureteric obstruction.
Okay, moving from fistulae to obstruction. Ureteric compression and blockage, caused by external sources within the female pelvis, pose perhaps the ultimate risk to kidney function. This is a potentially life-threatening problem that often starts silently with gynecological disease.
Indeed. And many different conditions within the pelvis are implicated, starting with a classic anatomical problem resulting from severe prolapse, uterine prolapse itself.
How can simple uterine prolapse actually cause damage way up in the upper urinary tract to the ureters and kidneys?
It happens specifically in cases of complete proscedentia, where the entire uterus is hanging outside the body. In this situation, the main supporting ligaments of the uterus, particularly the Mackenrod or cardinal ligaments, become enormously elongated and stretched.
Okay.
Now, the ureter runs through the base of these ligaments. As the ligaments stretch and are pulled downwards by the prolapsing uterus, the ureter gets dragged down too, causing it to become looped and often acutely angulated or kinked where it enters the pelvis.
Ah, so it gets kinked like a garden hose.
Exactly. This kink immediately obstructs the free flow of urine from the kidney down to the bladder. This leads sequentially to hydroureter, a dilated swollen ureter above the kink, and then hydronephrosis, swelling and pressure buildup within the kidney itself. This is a serious impairment of renal function, and it makes these patients quite poor surgical risks for the necessary prolapse repair until the obstruction is relieved.
So, what specific preoperative preparation is mandated by the sources to try and reverse some of these ureteric changes before attempting the major prolapse surgery?
To try and mitigate this risk, the patient requires specific preoperative preparation. The source mentions using vaginal tampons soaked in a mixture of glycerin and acroflavine, inserted daily for several days before surgery.
What does that do?
The glycerin helps to reduce local edema and inflammation in the prolapsed tissues, and the acroflavine is an antiseptic. This can allow the pelvic structures to retract somewhat, potentially allowing the ureteric angulation to partially straighten out, which can temporarily decrease the degree of hydronephrosis before the definitive surgical repair is undertaken. It aims to improve renal function pre-op.
Makes sense. Pelvic tumors, too, are highlighted as major offenders in causing ureteric compression.
Absolutely. Any significant mass that becomes firmly embedded or impacted within the pelvic space can compress the ureter against the rigid, bony sidewall of the pelvis. This includes things like large uterine myomas, fibroids, ovarian cysts, both benign and malignant, extensive endometriosis, chronic pelvic inflammatory disease, PID with adhesions, or tumors arising in the broad ligament.
And pre-op investigation is key here.
Yes. Urological investigation, usually with an IVP or CT urogram ultrasound, is considered mandatory before operating on large pelvic masses, because the source suggests that approximately half of these patients will already show some degree of ureteric obstruction preoperatively.
Is the damage usually reversible?
The positive news is that in many cases, especially with benign tumors, surgical removal of the compressing mass allows the ureter to decompress, and the urinary tract returns to normal in about 70% of cases. However, and this is a big however, if the obstruction is caused by chronic PID or advanced cancer, the associated inflammation and infiltration often lead to permanent scarring and irreversible stricture formation in the ureter wall, even after the primary disease is treated.
Which brings us back inevitably to carcinoma of the cervix. This poses the greatest, most consistent, and most devastating danger to the ureters.
Yes, the anatomy here is just unforgiving. The ureter passes through a specific tunnel in the perimetral tissues at the base of the broad ligament, very close to the cervix. These tissues are frequently the first site of lateral spread for cervical cancer. The tumor infiltrates these tissues and directly compresses or encases the ureter, despite the ureter having a fairly tough outer sheath.
And this leads to that absolute clinical rule.
Yes, it leads to what the source calls an absolute dictum. No case of cancer of the cervix should ever be treated, whether by surgery or radiation, without a preliminary urographic study, like an IVP or CTU, to assess the status of the kidneys and ureters first. The presence of ureteric obstruction before treatment begins implies locally advanced disease and carries a definitively poor prognosis.
Yeah.
It often significantly influences the choice and urgency of treatment.
And we really must reiterate that stark, fatal consequence for the patient if obstruction occurs and isn't managed.
It really bears repeating because it highlights the ultimate danger of this gynecology-urology intersection. The majority estimated at 70% of patients with advanced carcinoma of the cervix die not primarily from metastatic spread of the malignant disease itself, but from bilateral ureteric obstruction, leading to progressive kidney damage and ultimately fatal uremia, renal failure.
And tragically, the very treatment designed to cure the cancer can sometimes cause a delayed form of this exact same problem.
That's the cruel irony of long-term complications. Effective radiation therapy delivered to the pelvis to treat infiltrated perimetrial tissue inevitably causes subsequent fibrosis and scarring in those irradiated tissues. This post-radiation scarring, often developing slowly over months or even years after treatment, can contract and gradually strangle the ureter as it passes through that fibrotic tissue bed.
So a patient can be cured of her cancer,
only to succumb later to chronic, often silent, progressive ureteric obstruction caused by the curative treatment itself. It underscores the need for long-term urological surveillance after pelvic radiotherapy.
Finally, in this section on obstruction, we need to look at the risks associated with healing itself, particularly after a fistula has occurred or been repaired.
Yes, even seemingly positive events can have negative consequences. Spontaneous healing of a ureteric fistula, while seemingly gratifying, often occurs with significant scar tissue formation at the site of the previous hole. This cicatricial stricture, a scar-induced narrowing, can be just as disastrous for the upstream kidney as the original injury by blocking drainage.
And surgical repair isn't without risk either.
No. Similarly, surgical rejoining of the ureter, a procedure called ureteric anastomosis, which might be done following a high ureteric injury, is also frequently followed by stricture formation at the anastomosis site later on. These patients require careful, long-term urological follow-up. Periodic dilatation of the stricture by a urologist might save the kidney, but unfortunately, a significant number of these cases ultimately end up requiring nephrectomy removal of the damaged kidney.
Okay, let's dedicate the necessary depth now to a unique physiological state pregnancy, which has profound effects on the entire urinary tract. And importantly, these effects are not always due to simple mechanical compression from the growing baby.
That's a really important point. The major changes we see in the urinary tract during pregnancy are primarily due to the specific systemic action of the hormone progesterone. Progesterone has a relaxing effect on virtually all smooth muscle throughout the body.
Not just the uterus.
No, not just the uterus. It affects the smooth muscle on the walls of the ureters, the bladder, the gastrointestinal tract, the gallbladder, even blood vessels and the pelvic ligaments. This generalized smooth muscle relaxation leads to a physiological hydroreader, dilation of the ureters, and some degree of hydronephrosis, dilation of the renal pelvis and calyces in the kidney.
What's the typical timeline for these changes during pregnancy?
The earliest signs of this ureteral dilation actually appear quite early, often by the end of the first trimester or early in the second trimester, say, by the 4th month of gestation. This is long before the uterus is large enough to cause significant mechanical compression purely by its size.
Right.
These changes then tend to maximize towards the end of pregnancy, at term. After delivery, this physiological dilation resolves, but it does so quite slowly. It typically requires the entire puerperium, the 6 weeks after birth, and the urinary tract usually returns completely to its normal pre-pregnant state by about the 3rd month postpartum.
So it's a normal physiological change. When does it cross the line and potentially become pathological or lead to permanent damage?
The main risk arises because this dilation and the relaxation of the ureteric muscle leads to urinary stasis. Urine doesn't flow down as quickly. A dilated ureter with sluggish flow is much more susceptible to ascending infection from the bladder. So, if a significant urinary tract infection occurs during pregnancy specifically, pyelonephritis of pregnancy, The resulting inflammation and potential scarring within the already dilated and potentially compromised ureter can prevent it from ever fully completing its involution, its return to normal size and function after delivery. This can result in permanent damage and a state of chronic pyelonephritis, which poses a long-term risk to the patient's overall renal function.
And there's that frequently cited observation about asymmetry. Why is this physiological dilatation often more noticeable and sometimes more severe on the right side compared to the left?
Yes, that's a classic finding. If it were purely due to simple pressure from the growing uterus, you might expect it to be symmetrical, or maybe even worse on the left side, where the left ureter often crosses over the iliac vessels at the pelvic brim. However, the dilatation is consistently found to be more frequent and often more pronounced on the right side.
And the proposed reason?
The most widely accepted explanation relates to the normal dextrotation and dextroposition of the pregnant uterus. As the uterus grows, it naturally tends to twist slightly and tilt towards the right side of the pelvis.
Okay.
This rotation is thought to cause some degree of distortion or even mild kinking of the right ureter as it passes over the pelvic brim, possibly near where the ovarian vessels cross. So it's likely a combination of this subtle mechanical factor on the right side, superimposed on the underlying generalized smooth muscle relaxation caused by progesterone, that creates a greater predisposition for stasis, dilatation, and potentially infection on the right compared to the left. #TagOutro. So wrapping this all up, this deep dive really confirms that the gynecologist absolutely must possess a deep functional mastery of the urinary tract. It needs to be treated with the same clinical reverence, really, as the reproductive tract itself. We've synthesized from the sources that common urinary symptoms are almost inherent in gynecological practice, often directly caused by the underlying pelvic disease or as a consequence of pelvic operations or difficult deliveries.
Yeah, and some key clinical takeaways really stand out, like the absolute necessity of ruling out neurological causes immediately if a patient presents with retention without pain, that absence of pain being the critical diagnostic cue pointing towards potential spinal pathology.
Absolutely.
We also saw the profound yet often very treatable impact of hormonal deficiency, perfectly exemplified by the urethral syndrome in postmenopausal women. It's so effectively reversed, usually within about 3 months, just by using short-term vaginal estrogen cream.
It's a great example of targeted therapy.
Yeah.
And we simply cannot, must not, overlook the potentially life-threatening consequences of major structural failure or obstruction, whether it's through obstetric trauma causing devastating fistulae, particularly in resource-poor settings, or the insidious silent compression of the ureters from advanced cervical carcinoma.
Right.
That ever-present risk of bilateral ureteric obstruction leading to fatal uramia means that performing pretreatment urography in relevant cases remains, as the source insists, an absolute dictum for ensuring patient survival, preserving long-term quality of life. Understanding that crucial difference between, say, temporary postoperative occlusion and a permanent fibrotic stricture, that's truly the mark of professional mastery in this area.
We covered the organic causes, the infectious causes, the mechanical causes pretty exhaustively, I think. But we also highlighted that tricky non-organic diagnosis, bladder neurosis, where if the urine is sterile, cystoscopy is completely normal and no local organic cause can possibly be found.
The recommended treatment shifts dramatically away from drugs and surgery towards things like psychotherapy, bladder discipline, and maybe sedatives.
Which leaves us with our final provocative thought for you, the listener, to ponder as you integrate this deep dive into your own understanding.
Given that chronic urinary complaints, whatever their cause, can profoundly impact a patient's emotional well-being and physical quality of life, how deeply, and perhaps for how long, should we commit clinical resources to pursuing those psychiatric or behavioral interventions like bladder discipline before we truly accept a functional diagnosis like bladder neurosis, especially after exhaustive organic pathology has been meticulously excluded? Where exactly does the line between physical medicine and behavioral therapy blur when managing these persistent, distressing, but organically unexplained chronic symptoms?
A really profound question, I think, to integrate into your clinical thinking. Thank you for joining us for this deep dive.